Good afternoon, everyone. Thank you for joining us for the Advanced Echo Teaching in Critical Care this week. It's a great pleasure to introduce my friend and colleague, Arvind Rajamani, who's one of the intensive care specialists here at Nepean Hospital in Sydney. Arvind, thank goodness, is going to be teaching about how to image the lower limbs with vascular ultrasound. You need Arvind doing that rather than me. I'm really looking forward to this, Arvind, because you've been promising to teach me this for a number of years now, so I'm looking forward to finally hearing it. So over to you, Arvind. Thank you very much.
Thanks, everyone. I realized just 10 minutes ago that I actually have a presentation on this. So this Learning Ultrasound Critical Care program is something on basic competency. And about 6 or 7 years ago, I thought that people who sign up for the CCPU level basic echo, basic ultrasound thing, I thought I'll start them off with DVT as a gentle introduction to the hand-eye, the probe transducer movement and understanding physics and all that. And then they would progress on to doing echo and lung ultrasound and everything. And therefore I invested quite a lot of time in creating videos, talks and so on, and tests and so on. It's finally becoming useful to me 6 or 7 years later, because what happened, I found, was people did do the DVT, but they would just, after that, they would go away. They wouldn't do any heart or lung. I found that the basic trainees only have time for about 3 or 4 months. Therefore, I've abandoned this as the introductory module for the lung program and gone straight to heart and lungs. But it's a very, very, very simple thing. And the learning curve for people like you will be literally 2 scans. There is nothing at all in this. There are some tips and tricks, but overall it's extremely easy for people who can do cardiac echo. The anatomy is extremely easy. Now the clinical relevance, we all know that when we have patients, we are primarily interested in pulmonary emboli. And the good thing is that 90% of the PEs are caused by above knee lower limb DVTs. And that's the only thing that I do, but the principles of this will extend to any DVT anywhere else. There are 2 important veins, the common femoral vein and the popliteal vein. These are the deep veins. The long saphenous vein is not traditionally, it's not considered to be a deep vein, and the incidence of embolism from that vein is not that much. The incidence of embolism from the infrapopliteal veins is also nothing. Therefore, you can safely ignore them. Having said that, it will be a good idea to do surveillance Dopplers to see whether they have extended. Okay. And so the anatomy, starting from the IVC, from the lower part of the IVC, you have the common iliac vein, etc. Now the internal iliac, and when you have the groin crease, that's the location from which we want to start. Okay, we really cannot image by ultrasound. We cannot image this area. Okay, this is usually by inference that we say that you have a DVT of that location. Now the ones that we are interested in is here, and you start off from the common femoral vein, and then you look at the deep femoral vein, and then the popliteal vein. We do not do anything at this location below the popliteal. In the inguinal crease, it's just inferior, and you have this acronym, vein, artery, nerve, and that's from medial to lateral. So if you have right and left, then it's VAN and VAN. Okay. And pictorially, I'll just shift this thing here. Okay. This is which side? This is the right leg. Okay. And you have the Mickey Mouse sign on transverse view. When you have the probe face, the one thing is that the transducer is always going to face the right side, regardless of which limb you image. Okay. Now, when the transducer faces the 9 o'clock position here, okay, then on the right side, the Mickey Mouse sign is made up of the common femoral vein, which is posterior and in the middle, in the center, and then the long saphenous vein and the femoral artery are the 2 ears of the Mickey Mouse. And for the right side, the femoral artery is on the right, and lateral, and the long saphenous vein is medial, and for the left it will be the opposite. Okay. In the popliteal vein and the artery are both in the popliteal fossa, and the vein is always anatomically posterior to the artery, which means sonographically anterior, sonographically superficial, because we are going from posterior to anterior. Okay, the more superficial structure will be the vein, and the more superficial, the deeper structure will be the artery. And the best way to find that out is actually by going by tracing the artery from the thigh downwards, from the vessels from thighs downwards. Okay. Now, while you're scanning, it is extremely common in the normal individual to collapse the veins just by applying by pressing the transducer hard. And when you can't see the veins at all, just release the pressure, and it is very common for you to just suddenly spot the vein, because you have been literally doing a compression test, a compressibility test. Okay. So when you can only see the artery and you're hunting around for the vein and you can't find it, most likely it is because you've just pressed too hard. What are we looking for? Okay. Now, normal vein, DVT, and these are the things that we want. Okay. Echogenicity of a normal vein is completely anechoic. A DVT may have echogenic material, and importantly, you have to compare it with the artery, because if you have echogenic material in the artery as well, perhaps your gain is too much. Okay. Compressibility of a normal vein is fully compressible, whereas a DVT is either partly or not compressible at all. And this is the hardest sign for DVT scanning. It's like the presence of a gallstone and sonographic Murphy sign for biliary tract. Okay, for cholecystitis. Compressibility is what you always should look for. And how much pressure should you apply? Just enough pressure to apply to mildly distort the artery. If not, you haven't compressed hard enough. Okay. I told you in the previous slide that it's very common for a normal vein to get completely occluded by just routine pressure. When you have somebody with severe tricuspid regurgitation and right heart failure, then their venous pressures are high, and you need to apply more pressure than normal. So a good sign will be when you start distorting the circular shape of the artery, then it means that is enough pressure, because that's more than systemic arterial pressure. Color Doppler is you look for uniform filling in a normal vein, and in the DVT you may have a filling defect, but remember from your physics that what we are doing is we are actually, if that's the flow of blood, the scanner, the probe transducer is 90 degrees. So it is very, very common for you not to have flow, not to see flow on color Doppler. Okay. So you will have to angulate your transducer a little bit in order to create that angle and create a Doppler effect. Okay.
Arvind, can I ask a question? Some of the 2D features that you're seeing there with the compressibility and the echogenicity, can you tell the difference between chronic or subacute versus the acute thrombus with that?
I believe not. I think that is the echogenicity. So just like the echogenicity of a thrombus in the heart, I believe that I've asked the sonographer before, and I believe that you can't. My father had a DVT, and we had scans done every 6 months. And I asked Richard Huang at that time. He just said that a chronic DVT looks more echogenic, more hyperechoic than an acute DVT. But apart from that, you can't. So you just do surveillance scans and you compare. The other thing is that a chronic DVT starts getting endothelialized and starts actually becoming part of the wall. So you might actually not see the DVT, you'll just see the wall thickened, I believe. Okay. Then color Doppler, as I said, color Doppler is, because of the angle dependence, it is unreliable. And you have to create the angle to create the Doppler effect. And finally, the same thing with pulse wave. The pulse wave thing is what we're looking for in pulse wave is a respiratory variation and augmentation with calf pressure in a normal vein. Okay. Now, if you have a DVT that is proximal to the location you are scanning. So if that's the heart, okay, and you have a DVT, say a full DVT of the inferior vena cava or the iliac vein, then if you are scanning, say, the common femoral vein downstream, you will not have the respiratory variation from the thorax being passed on here. So the lack of respiratory variation is not necessarily a sign of a DVT at the location you are scanning. It is a sign of a DVT that might be more proximal, more towards the heart. However, there are lots of caveats here. One, like any respiratory variation, it is effort dependent. Secondly, if you don't have a completely occluding DVT, the lumen is only partially occluded, you can still have respiratory variation, particularly when you have a strong respiratory effort. So it's one of the signs that you look for diagnosing iliac vein DVTs when you have pelvic fractures, for example. But I'm not experienced in that, and I've been told that you have caveats. Augmentation with calf pressure is the opposite. It looks for a more so if you're scanning the femoral vein, or maybe say the popliteal vein here, and you squeeze the calf, so you squeeze the calf here, then if you don't have augmentation, it means that in between the anatomical location where you're pressing and your probe transducer, there is a blockage. Okay, so it's not necessarily at the location of the transducer, but more downstream to the transducer. Again, the problems with this are, I believe that you can actually trigger an embolism, a pulmonary embolism, if you have a soft clot. That's number one. Number two, I believe pain is a very big issue. So if you have a fresh DVT and you have a very painful leg, then you can't use this. Okay. So therefore, because of all the caveats with this part here with the Doppler, the most important hard signs are these two. Okay. And number one is the lack of compressibility, and number two in that order is you may have echogenic material in the lumen. Okay. Any questions so far?
Arvind, it's Ravi here. I had a question with the respiratory variation. Does positive pressure ventilation change that factor?
I don't know. I think it is the same as the IVC, isn't it? You'll have just the opposite. Instead of inspiration pulling in the blood, you'll have expiration pushing out the blood. So I think you will still have a phasic variation, but in the opposite phase. Okay. The other thing about respiratory variation, which I didn't say, is I believe that there is actually no magic value of say 10% or 20% because it is so effort dependent. So again, the sonographer said that it's just binary, yes or no. If it's yes, it means that it is not a completely occlusive DVT proximally. If it is no, then it might be a number of other things, including one of the differentials being a fully occlusive DVT, but you have the other things such as lack of effort. For example, with IPPV, I'm not sure whether the lung protective ventilation will actually create enough respiratory variation in somebody with already a high baseline P. Okay, so okay, now how do I scan? This is the sequence that I use for venous scanning, venous duplex at any location. I always start off with the 2D and I look for compressibility at that location and then the echogenic material at that location. And importantly, if you're starting from the thigh, if you're starting from the thigh downwards, okay, right at the beginning, and this is the same thing that I use for lung ultrasound as well, I just apply gel all over the projected course of the vein so that you don't have to keep lifting the probe off. Okay, having a lot of gel on the probe doesn't really work that well. Just apply a linear, a lot of gel along the projected course and start at one location and keep going cephalad and caudad without lifting the probe. You'll be surprised how difficult it will be to locate the vein in the mid and lower thigh without having followed its course. The best way is to actually just follow its course. And if you keep the vein in the center, then even a tiny vein can be visible. Whereas if you lose it, then you have to start from a location where you can see the vein again and then follow it down. So when you have a dressing down, at some location where it's interrupted, it often becomes a little bit difficult. So what I often do is, if I can't see the vein, I go to the popliteal and then go trace it Keflad. Okay, right. So the sequence of events, I start off high up for the saphenofemoral junction, and at each location, I do a compressibility and I look for echogenic material within the lumen. Okay, then once I get these two, I fill it up with color Doppler within the vein, and then pulse wave Doppler for augmentation, etc. As generally those things I only do once or twice. So once proximally and once at the popliteal vein. Okay. Now at one longitudinal, rotating the probe longitudinal, which with a probe marker facing the heart, I do it mainly at the saphenofemoral junction to locate the superficial and the deep femoral veins. Okay, I don't really do it at other locations. You do not apply compressibility when you're longitudinal, because for compressibility, the whole of the, if that's the vein, the whole of the transducer must be compressing the vein. Whereas if you're applying, if you're longitudinal, then it is possible that you're at one edge of the vein, and therefore you might not have uniform force over the vein. So there's no point doing compressibility when, especially because remember, as you're going more caudad, more towards the knee, it'll start getting a little more medial, and it's a curved surface, and with gel on it, when you're pressing it, there is a high tendency that the probe will slip just half a centimeter, and that's enough for you to lose the vein. And you might mistakenly interpret that as, I can't see the vein, therefore it's compressed. Okay, you've just gone away completely from the anatomical tract of the vein, the plane of the vein. So apply compressibility in the transverse. Okay, and now what do you do? This is actually the internal jugular vein anteriorly, and this is the common carotid posteriorly. This is pre-compression, and then when you occlude it, it's completely this area here. Can you see my mouse? Okay, so this area, this is the occluded, completely compressed IJ. Okay, this is a normal finding of a color Doppler with the artery. Now, red and blue is not artery and vein; it's just the direction of the direction at which the blood is flowing towards or away from the transducer, and that depends on how you are holding the transducer. Okay. If you are holding the transducer in a cephalad to caudad direction, then the blood is going to flow towards the transducer. So venous blood will be blue away. No, venous blood will be red, and arterial blood will be blue. And if you want to do it the opposite way, you either manually change the color settings, or you actually have to angle the transducer in such a way that you are imaging from caudad to cephalad direction. Do you understand? Okay, so don't go by the color of the blood, it's the angle. Now in a DVT, you can see here, this area here, there is a small filling defect. I think this one is here is power Doppler, if I'm not mistaken. Okay, pulse wave Doppler, what you're looking for now, this is the artery here. Okay, this is the artery, and this is the phasic variation in the vein. Okay, and once again, if you look at the venous presets, you will find that there is an automatic angle of the transducer, unlike any other linear probe where the box, this is the window of the transducer. When you choose the vascular, the venous Doppler settings, you will automatically see that it's like this. Okay, and that is because it creates that angle for you. Otherwise, you're not going to be able to see. The cosine of 90 degrees will be 0, and you can't see any blood flow whatsoever. Okay, so the machine does that as a preset for you. You can also manually do that by angling the transducer a little bit so that you create that angle. Okay. Findings in the DVT, I don't know how well this is projecting, but can you see a small, that area there, you have that echogenic material here. Okay. So here, this is all dark, and just here you have some specks of echogenic material. It can be very, very subtle. A fresh DVT will be extremely subtle. And it's that fresh DVT that you shouldn't miss, because that has the highest risk of embolizing. Okay. Now with compression, you find that it's actually not getting compressed, and see how the artery has actually got distorted. So the artery here is nice and it's circular, whereas here the artery has got distorted because of the pressure. It's become wider and become narrower, and despite that, DVT is preventing the vein from getting fully compressed. Okay. Now you always have to compare it with the adjacent artery, and you also have to confirm it with color Doppler. If you have DVT, then you will have a lack of uniform filling in the vein, whereas you'll have good filling in the artery. Okay. False positive for echogenic material within the vein, as usual, is increased gain. And then lymph node for a vein is an extremely common mistake. Because a lymph node will have a typical feature of a DVT vein. Okay. How do you, and it won't be compressible either. It won't have blood flow. Okay. It ticks all the boxes. So a simple thing for a lymph node is that when you rotate the probe longitudinally, it will remain circular. Okay, a lymph node will be circular in both directions, whereas a vein will become will become a longitudinal tube in the longitudinal direction. Color Doppler, there is no flow at all here. Now I have struggled with this conceptually. When you have a partially occlusive DVT, then I would imagine that the flow becomes more turbulent and therefore the velocity increases. So I'm not sure. And that's one of the things with pulse wave Doppler as well as color Doppler. Here you can see that there seems to be a filling defect here, but with pulse wave Doppler down below, there is no flow at all in that location. Okay. Whereas I would imagine that if you have a partially occlusive DVT, the flow velocity might actually increase. I don't know. Somebody has to read it and let me know. Lack of augmentation. So when you press on the calf here, there doesn't seem to be any augmentation whatsoever. Whereas normally you should have a nice, when you press, you have to have a nice, you'll have a spurt in the blood flow. Now this actually looks quite phasic. I don't think anyone would have done 4 or 5 augmentations. You just do one augmentation maneuver. Now, what do you look for again? So what are we looking for when we're doing a DVT scan? 2-point compression test and then ancillary tests. And the 2 points are, is the femoral vein compressible at the saphenofemoral junction? And is the popliteal vein compressible at the popliteal fossa? I've been told that all the if you rule out a femoral vein DVT and a popliteal vein DVT, you do not need to worry about the rest of the thigh, above knee the deep femoral vein. Okay. Now the superficial and deep femoral veins. Now I do this anyway because it's actually not a big deal. It only adds about 3 or 4 minutes of extra scanning time, and just scanning from cephalad to caudad and just applying pressure, about 2 or 3 times in between is not a big deal. You do not have to do all the other complicated things like Dopplers, etc. So I would recommend, even though these two, for point of care DVT ultrasound, it's been shown that the specificity and the sensitivity of the 2-point compression is as good is good enough compared to a whole upper limb, a whole above knee duplex. My personal practice is to just do the whole limb anyway. Okay. And then the ancillary test will be for echogenic material, and is the femoral vein compressible along the course of the thigh, and is there color Doppler filling, is there augmentation, is there phasic? So all of these will be the other basket, and you don't you would do it, but the most important thing that you have to do is compress at these 2 points at least. Okay. Now, what is the technique for the femoral vein? The position of the patient is supine, lower limb is extended, slightly externally rotated so that the groin crease. It's no different from putting in the femoral CVC, the same anatomy, the same position and the same anatomy. Okay. You should take the linear probe in all instances except in the morbidly obese patients where you might need the abdominal probe or the curvilinear probe. Do not take the phased array cardiac probe because the footprint of it is small, and therefore compressibility, you might not be able to compress the whole of the vein. So you ideally choose the linear probe, but if the superficial fat is too much, or even swelling is too much, and the depth is not good enough, then it'll be okay with an abdominal with a curvilinear probe with a reasonable depth. This is at the level of the cephalofemoral junction as well as the popliteal fossa. For the thigh, except in the smallest of patients, you might almost always need to change over to the abdominal probe because it's deep seated in the thigh. So in these two locations, linear probe should be okay for most people, and here the curvilinear or the abdominal probe in between. But the curvilinear or abdominal probe should work for virtually everywhere throughout, from cephalad to caudate. 2D probe is transverse. It always faces the 9 o'clock position or the right side for both legs. And when I say 9 o'clock, even for the popliteal fossa, it'll be 9 o'clock. So when you're going posterior, you still go 9 o'clock towards you. Do you understand? So therefore, for the popliteal, you'll be facing, I think, medially, because you're going from posterior to anterior. Okay, let me just think. That's coming from memory. When I go to the popliteal, I'll see whether my memory serves me right. It's been a long time since I've prepared for this. So for the femoral vein, just below the inguinal crease, perpendicular to the skin, and search for the vein. And because all of us have done femoral CVCs, this is something that we have done, and this is something that we have already identified. You identify the Mickey Mouse sign, and you slide the probe, cephalad and caudate. Slide the probe so that the vein is at the center of the image. Okay. And in the Mickey Mouse sign, the most important thing you have to remember about the Mickey Mouse sign is that the artery is always anterolateral to the vein. Okay. Therefore, if you have a location where the artery and the vein, they are anteroposterior and not lateral to each other, that means you are not at the cephalofemoral junction. You are not at the cephalad junction. You are a little bit more caudate. You are already in the thigh. So every time you see the artery bang posterior to the vein, always slide the probe either cephalad and go and get it in such a way that the artery becomes slightly lateral to it, or you angle the probe, rock the probe in such a way, tilt the probe in such a way that you are facing the heart, and again you get that same thing. The only problem with tilting the probe and getting that image is that your compressibility is going to be affected because you are no longer perpendicular to the vein, and the pressure that you are applying with the probe may not transmit completely to that vein. Do you understand? Okay. So press the vein firmly, and every time when you are applying when you're doing the compressibility, it is ideally you have to be perpendicular to the vein and apply it 90 degrees or anteroposterior direction rather than angulated. You must see the femoral vein flattening completely, and if it doesn't flatten completely and the artery has started flattening, it means that the compressibility, it means that you're either not. See, that can happen either because of a DVT or if you're slightly off center. So if that is the field and your vein is here and the artery is here, it is possible that the pressure that you are applying may not go entirely over the vein, and this might get flattened. The artery might get flattened. Okay. So always try to make sure that the vein is in the center of the image so that the entire pressure is getting transmitted to the vein. But if it's not flattening completely, if it's not compressing, that's a positive test. Okay. The ancillary tests, look for this, all of these things. Okay. Popliteal vein, patient is supine. Lower limb must be slightly externally rotated at the hip and flexed about 20 or 30 degrees at the knee. Believe me, in an obese patient, this is a nightmare. Okay. And there are so many false the popliteal vein, you'll be surprised how many times the weight of the leg on the probe will compress the vein. So you'll actually be doing a compressibility test without knowing it. And often you'll have to withdraw the probe slightly in order to see the vein because the entire weight of the leg is on the probe. Okay. support the thigh with your non-scanning hand, and that's because you don't want that to happen. You want when you're imaging the vein, you want the vein to be fully open. Probe is transverse, facing the 9 o'clock position for both legs, and place the probe in the popliteal fossa, perpendicular to the skin, and then you start sweeping cephalochorda till you identify the popliteal vein. Once again, get the vein to the center of the image, and then you press hard in the posterior anterior direction, support the thigh or the knee so that the pressure that you are applying with the probe is not shifting the leg away from the bed for thin people in particular, okay? And it's actually being transmitted fully to the vein. And once again, the same thing, the vein must compress completely, okay? And same thing, echogenic material, color Doppler, pulse wave, and then you rotate the probe to the long axis for color Doppler, and so on, okay? When the popliteal vein can't be seen, as I said, the alternate positions are, you can, if it's possible to have the patient sitting, then you can hang the leg down the side of the bed. Prone position, if it's possible, and if you can't see the artery at all, then you'll just have to, you're in the wrong place completely, and you'll just have to slide the probe widely along the popliteal fossa. And this is the thing that I was saying, if you can see the artery but you can't see the vein, then it's most common thing for me at least is that the weight of the leg is resting on the probe and therefore is causing a compressibility test. And you just release the probe very, very slightly by withdrawing the scanning hand without losing complete contact, and eureka, you'll suddenly just get the vein will spring out, okay? And then when the vein is not compressible, you rule out a false positive by applying the counter pressure with a non-scanning hand to make sure that all the pressure is getting to the vein, okay? And as I said, how much pressure is enough? You have to, if you apply, if the vein is in the middle of the screen, and the pressure that you are giving is enough to distort the artery, it means that that is enough pressure, okay? What are the causes for lack of compressibility? One is DVT, and when you see this, because this is a hard sign, you always try, and because it's going to change your management and you're going to anticoagulate the patient, just spend that extra 10-15 minutes and look for the other ancillary signs, the echogenic material, color Doppler, longitudinal view, including Doppler. See whether you can do things like non-augmentation, etc. Okay. Then the compressing pressures may not be enough, and that's because you haven't centered, you've slipped laterally. Remember again, when you're pressing hard, especially for the popliteal vein, when the popliteal vein is tricky, and the leg is in an awkward angle. You are scanning from posterior to anterior, and then when you're pressing, the leg moves. So it's quite possible that the probe slips laterally. Okay, not enough pressure. We've covered that. Artery mistaken for the vein. This is also not uncommon. Okay, and if you're just do pulse wave Doppler for the flow velocity characteristics. Lymph node we've covered. Color Doppler. Lymph node will not have any color, but more importantly, you do it in two perpendicular planes, longitudinally and transversely. Okay. So in summary, we look for the above knee limb, lower limb DVT. Technical factors, make sure that the first image, you make sure that you do not have too much gain, and the clue for that will be too much noise in the artery and in the superficial structures. 2-point compression, and some of the ancillary tests are these, and these are some additional resources.
And Arvind, the additional resources you said, I might be able to put them up on our website. Is that okay?
Yes.
Thank you very much. That was awesome.
Any questions? There are some case studies.
Amazing.
Okay, let me go to the case studies. Now, one of the reasons I did this here is because the answers are in a different computer. It's been 5 years or so since I've looked at these, so I need to cheat and look at the answers. So Louise, you're here, okay? So, okay, just one after the other, please. Ben, where are we?
So we're up at the saphenofemoral junction. I can see.
Okay. Where? Which side?
Left.
Why?
The artery is lateral.
Excellent. So where is the saphenous?
I think we're distal to where the junction should be because it's almost swinging. I'm sorry, I'm pointing screen.
I don't think we are distal because the artery is lateral. What we are is, I think we haven't rotated well enough to get the saphenous vein as well. Okay, because see, the artery is actually lateral. Okay,
yeah.
The saphenous vein should be here for completing the Mickey Mouse.
Yeah.
So do not accept this image because the saphenous vein at the saphenofemoral junction is considered a deep vein. And if you have a saphenofemoral vein thrombosis, that you treat it exactly as you would a femoral vein thrombosis. Okay. So here, I don't know whether we are not able to see the saphenous vein because it's occluded by a clot, but I think it's because we haven't rotated well enough and we're not in the right enough plane for it. So make sure that you first get that before you do any of the other things. Okay. Then what else?
What else can I see here?
What did you say? What is the inference of this particular image?
So, I mean, the artery is collapsing with the pressure that's being applied. The vein is collapsing with the pressure that's being applied. The artery is being distorted. There's no echogenic material that I can see in this series, but it's taking a fair amount of pressure. There's a fair amount of distortion to the artery to lead to that collapsibility or the compressibility of the vein.
Okay. Now, 1 minute. I made it smaller because I need to, the zoom controls are coming in the way for me to, 1 minute.
So the point at which there starts to be arterial compression and distortion.
Okay, let's go frame by frame. You said that the vein is being compressed, okay? Tell me where the vein is full, whether the vein is completely compressed.
No, I don't think the vein ever gets completely compressed. Exactly. And you get arterial compression prior to getting even close to it. So exactly. The inference is that there's clot here.
This part of the vein is completely compressed, but this part of the vein is not completely compressed. So you have to have complete compression in order to say that the patient does not have a DVT. If not, then you have to go down the path of this is a non-compressible vein, and what are my differentials, and is it because I haven't centered the vein well enough? Have I angulated the probe? Is it perpendicular? Is the pressure good enough? And the answer to that is, regardless of the angulation of my probe, if the artery is getting compressed and the vein is not getting compressed, that's a serious thing. Okay. Yeah. And yes, we can't see any echogenic material, but here's where you should start doing all the other things. Firstly, get rid of this depth. Okay. Yeah. So that means that and then I don't know whether there is, okay, the focus seems to be here. If you get rid of the depth and get the focus to around the 3 centimeter mark, then rotate it in such a way that you also get the saphenous vein, and make sure that you can't see the saphenous vein, just look at whether see the location where it's not compressing. I would expect that the saphenofemoral junction would actually be thrombosed. Okay? Yeah. And then do a longitudinal thing, put color Doppler, put longitudinal. And one of the nice tricks I find is that put pulse wave Doppler, and you'll find that pulse wave Doppler keep changing the window within the vein. And you'll find that all over here, you will see flow, but the place which is not compressible, you will probably not see flow. Yeah. Okay. Right. Okay. Who's next? Ravi? Is that Ravi next? Okay. Yes.
So that looks like a longitudinal view of the femoral vein. Femoral vein, and we can see two echogenic shadows there. On the top, it looks like a valve, possibly because it's more thin. And on the bottom, it looks bright echogenic material which is attached to the endothelial wall. So possibly a thrombus. But I would like to confirm by doing compression and color Doppler and pulse wave Doppler.
Excellent. And the compression should specifically be applied at this location, okay? Because if you apply it at this location, so this is one of the areas where you can't just afford to say, okay, I'll do my 2-point compression and then a couple of points in between. You have to target the area that you are interested in, okay? Okay, a few important other things. The gain of this, what do you think of the gain?
In general, it seems a very bright image, and we don't have the artery to compare. But ideally, the lumen should be like anechoic.
Exactly. Look at everywhere. See, this whole thing, there's too much gain in the soft tissue. There's too much noise within the vein. And when you have a very DVT, an acute DVT, a fresh thrombus is a very subtle finding. And you don't want to have this kind of gain. You have to, you lower the gain to just have, you have an anechoic vessel. Okay. Right. Swapnil.
Yep.
Okay.
So it's obviously it says it's right femoral there. So I believe it's right femoral. Again, longitudinal section. Obviously, it's a pulse color Doppler which shows there is flow there, but it's not completely filling the vessel. So there's a possibility that there might be a thrombus there, but obviously like to check with compressibility and then see whether it compresses completely.
Correct.
Yeah.
Good. Very good. And see the color box. This color box is a rectangle rather than a rhomboid. Okay. That means that the machine has not done the autocorrect, or sorry, the angle correction. And when you don't have angle correction, it is quite possible that you can't see the flow that is happening at right angles to the transducer. So you have to create angle correction with your transducer in order to, if the machine is not doing it automatically for you, then you tilt the probe instead of imaging the vein perpendicularly. Image the vein perpendicularly for the compressibility, but for Doppler, you just tilt it either towards the heart or away from the heart, whatever it is, just to create that angle. Okay.
Okay. Yeah.
I think on this image, it's on the nerve preset, isn't it? It's a Phillips spark, right?
Okay.
So they automatically come onto nerve whenever you use the linear probe for some reason. But if it was in the venous preset, you'd have the angled box.
Great. Okay. 5. Okay. Who's next? Daniel? I'm looking at my cheat sheet because I can't see anything here.
Yep.
It's the right femoral vein.
Yep. So this is a still image in longitudinal. I can't tell much from this. I think perhaps we're seeing the vein and the artery interposed.
Yes, so it's in the still image. I think it's very difficult to say anything, but maybe there is there a suspicious thing here?
Yeah, there is increased echogenicity within that vessel, but I couldn't say for sure whether it's gain setting related or whether it represents a true finding. We'd need to probably look on a moving image and in different orientations and look for compressibility.
Here, I would actually argue against gain being a cause, because if anything, if the gain, if it's under gained, you shouldn't be able to see a any echogenic material. So if this was over gained, then I would say maybe consider if you have noise in the acoustic noise within the vessels, then that could be too much gain and you can mistakenly see echogenic material. Here, the gain is actually appropriate everywhere. And the fact that with this gain, you are actually able to see something, you have to be suspicious, and then you have to go transverse, do the compressibility test and everything else. Okay, back to Ben. So no, this one is the previous one. It's a little bit too fast. If you can't see it, then I can slow it down.
No, that's okay. Speed's okay as long as it loops.
I've made it slower.
So going from the label, it's in the right popliteal fossa, well, presumably in the fossa. And so what I can see here is I think it's in the final frame or the new final frame there. It looks like the vein is having near complete collapse. It looks a little bit, I mean, from what I can see on my screen, it looks a little bit like it's undergained. I'm struggling to see some of the detail. There's a lot more black there than what I'd like. Otherwise, it looks like the veins, or that the anterior, the closest structure to the probe, the anterior structure to the vein is collapsing almost completely, and I can't see any distortion of the artery.
Okay, just look at, so that's the vein, isn't it?
Yeah, so it's
okay.
Collapse a little bit further at the end, or is it the last frame?
Tell me at any location at all, it's fully collapsing.
No, in the last frame, on my left of the screen, it looks like in the frames approaching the last frame, there's echogenic material perhaps.
Correct.
And then at the end, it's not quite completely collapsed.
So throughout, it's just like the first one that you did. I can't see the vein, the entire vein completely collapsing. Okay. It's completely collapsing maybe at this location, which is, I think, medial. But here, there is always a lumen. And that's the place where you can see the echogenic material as well. It fulfills both the hard signs of a DVT. So it is not compressible completely, and it is also having echogenic material.
If there was no echogenic material, given that we're not seeing any distortion or collapse of the artery, would you say that it's just not being compressed hard enough?
Perhaps. So what you would do now is to actually apply counter pressure so that the leg doesn't move, the thigh doesn't move anteriorly towards the ceiling, because that's one of the problems with imaging the posterior with the popliteal vein, that when you're applying the pressure, you're actually lifting the leg off in the small patients. Okay, so you make sure that you apply that counter pressure, and while you're doing that, also remember that your scanning hand, suddenly it becomes, the ergonomics are not good enough. So it's also easy for you to slip away medially and laterally. So you'll have to be, this is it's a little tricky. You know, when I say little tricky, literally you can master it within the first scan. Okay. It's very, very, from a learning viewpoint, DVT scanning is extremely easy. And right from the first scan that you see, you'll be able to do it easily enough. Okay. Some of the obese patients, some of the really small patients, you'll just have to use these extra tips, that's all. But I would say that in the presence of this echogenic material, as well as the lack of compressibility of that area, I would call this a DVT. But I agree with you that you have to apply a little more pressure to compress the artery. And then you also apply color Doppler and look up. Whenever you have a positive finding like this, double check it or triple check it using all the other ancillary signs. When it's fully compressible, you don't have to worry. Unless you have completely gone off the plane of the vein by the probe slipping about 2 or 3 centimeters, and you now can't see the vein at all. You're not imaging the vein at all. That, at this level, it shouldn't happen. At the very basic, junior doctor level, yes, it might. But at your level, all of you will be fine enough to be, you'll be skilled enough to identify that. Okay. Ravi, which image is this? This is number 8.
So it's very difficult to make out which site it is. But what I possibly we are trying to compress, but
See, whenever it is medial and lateral relationship, it has to be the saphenofemoral junction.
okay.
Everywhere else, it is an anterior-posterior relationship. Okay. The only location where it is medial and lateral is the SF junction. So this has to be the SF junction, and depending on which you think is the artery or the vein, then you can say whether it is right or left. Okay. So this must be the common femoral, and I think that this is the artery, which means the vein artery. This must be the right side. Okay, right saphenofemoral junction.
So obviously it looks like it's not compressible. It's not moving at all.
But what is the problem?
I can't see the Mickey Mouse sign.
Yes, so you can't see the saphenous vein. That's the first thing.
And it during
but it's not compressing at all. This has to be a DVT, correct?
No, but it's not central in throughout the. It looks like the probe is slipping slightly.
Perfect. That's the problem. So you have the person who's done it has actually, the probe is just going all over the place, and the vein is going from the middle of the screen to one edge of the screen, and that's why the pressure that is being applied is not effective enough. Okay, and in fact, you can see that the artery is getting a little bit flattened as the pressure is being applied, because the artery is coming bang in the middle of the probe. Okay. See, that's what I said. It's so easy. It's a very, very easy skill to learn and interpret. What is this? Okay, here what I've said is that it's not compressing, but the artery is not distorting, and therefore I don't think so. Therefore, you just need to apply more pressure. Okay, I'll just go to the next one. Wait, number 10.
Arvind, we've probably got time for one or two more, if that's okay.
Okay. Yes, I only have answers for one or two more. Swapnil?
Yeah, so looking at this, looks like a left popliteal. And again, the vein, most likely this looks like a longitudinal section.
No, this is the vein here.
This is the vein, okay. It's really, and it's not compressing with the pressure applied. Yeah, so vein and artery, okay. So, and then it's not compressing completely. So, very high probability of DVT.
Yes.
There.
Yeah. 11 and 12. Daniel, last one.
Sorry, I was muted. So this is on the left side and probably near the saphenofemoral junction. You can see the artery on the right of the screen, the vein on the left of the screen. There does appear to be echogenic material within the vein, which is non-compressible. So I think this is a high likelihood of a DVT at that site.
And next steps will be make it long. I'm going to put some color Doppler, put some pulse wave Doppler, and I would just put pulse wave Doppler throughout the in all the locations within this vein to see whether there are some places where there is flow and other places where it isn't. And that will, if you have the same angle, then it means that the lack of flow must be because of lack of pulse wave must be because of lack of flow.
Okay. Oh, and it says that this is the same patient as the previous slide, which in that case means they've got thrombus potentially from the popliteal all the way up to the SFJ, which is very extensive and significant DVT.
I think this might be a patient who had a pin put into her metatarsal 2 days before she came to ICU. And I don't know how that pin triggered such a big thrombogenic response, but she ended up having a clot right from the gastrocnemius all the way down, all the way up to the iliac, and embolized it, and through a patent foramen ovale, she ended up having a massive stroke, as well as renal and splenic, and it was just awful. She became brain dead. And that orthopedic surgeon was just beside himself. No. Anyway, I think that's it from me. There are a number of other, another 13 or another 10, 5 or 10, but it's easy. You guys will find it extremely easy to scan and interpret.
Arvind, thanks very, very much for all your time, and thank you for taking us through those cases as well. That was really great, and I'll put it up on our education site. Thank you very, very much indeed. Are there any last things, Arvind?
Thanks, Arvind.
Thank you. Thanks.
Ravi's got one question.
Sorry, Arvind. Suppose we find, a positive finding in the common femoral. Do we have to do then distal veins, or that should be it?
You want to find out how big it is, because again, the response to treatment, if it's becoming worse on treatment, it's just like with anything else. If you find B lines or consolidation within the lung, then you want to see how big it is. And then you want to monitor it.
And when we report, do we then look at the longitudinal extent of the clot, or do we just say?
See, I think I would just do multiple. I would do longitudinal, but I would do multiple transverse levels.
Okay.
Because the compressibility is the important thing. So you keep doing multiple transverse levels and keep looking at compressibility, and then say it's extending from so many. It's such a long. It's a 10-15 centimeter clot extending from halfway between the thigh to the SF junction, that kind of thing. And in that instance, if it's actually going all the way to the SF junction, you want to see whether it's extending into the iliac as well. So make sure you do some phasic variations with respiration.
Can I quick? Sorry, I know it's a DVT and vascular, but if there's a clot in the artery, femoral artery, how do you diagnose it? Because obviously compressibility will not be applied. So it's only Doppler, I guess?
I think so. See, I think that unlike a vein where echogenic material, it's a low flow state. And I think in an artery, if you have echogenic material, then I think pulse wave Doppler will be, if you have pulse, I say the answer, I'm making it up, but I think from sense, it makes sense that if you put pulse wave at multiple locations in the artery and you don't have flow in one area, then, and you have echogenic material, I would argue that I think would be an indication of a thrombus. And again, go longitudinally, put color Doppler, angle correct, etc.
Thanks.
Arvind, thank you very much, buddy.
Thanks, everyone.
That was brilliant. Guys, I'll see you next week. And I guess next week, I'm sorry, I only sent the questions out yesterday, so we'll go through some questions next week, okay? And then we'll get ready for a practice exam after that. Okay, guys, thanks very much indeed. See you next week.
Thanks. Bye.
Thank you.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.